Pankaj.
Video is on.
A very good evening to one and all. Wishing all a happy Dasara festival in advance. I heartily welcome all the members of API, CSI, ICP, LAI, CCDSI, and various other organizations delegates who have joined. On this occasion, I welcome our senior most guest of honor, Dr. P.S. Shankar, Professor Emeritus RGHS Bangalore and Distinguished Professor KBN University. I welcome our today's chief guest, Dr. Jyotirmay Paul, President National API from Kolkata, a dynamic personality who has taken national API to an international level, a great academician and a visionary personality liked by a whole API family in the country. I also welcome our other guest of honor, Dr. Dhiman Kahali, President-elect National CSI from Kolkata, a great academician and a researcher, as he is held up in Durga Puja, as everybody is aware in Kolkata. But he was kind enough to send a message to audience in the World Heart Day. I also welcome Dr. Raman Puri, Chief Cardiologist and President Lipid Association of India, who has made LAI name globally, as others are following our guidelines. As he is held up in other meetings, he will be joining shortly after half an hour. I welcome Dr. Kamalesh Tiwari, Dean ICP from Muzaffarpur, who had taken ICP to an international level and making many arrangements for the conference of Epicon 26. I welcome Dr. Muruganathan, Director PRF and past President Dean EPI, who is currently in USA to attend ACP conference, will be joining if time zone permits. I welcome Dr. A.N. Rai, Founder President of National CCDSI from Gaya, a great clinician. He formed Clinical Cardio Diabetes Society of India to maintain the importance of clinical medicine in the country, now which is spread over nationally as well. I also welcome our today's dynamic speaker, Dr. Dev Palajani, a doyen in the field of cardiology in the country from Mumbai, who was the past president of CSI and API as well. I also welcome our chief moderator, Dr. P.C. Manoria from Bhopal, a great academician, teacher par excellence, who was the past president of CSI and API as well in the country. I welcome our own panelist, Dr. Nagaraj Desai, chief cardiologist from Bangalore and the chief advisor of Lipid Association of India, Karnataka. I welcome our own faculty, Dr. Vivek Javdi, chief cardiothoracic surgeon and chairman Fortis Hospital, Bangalore, a dynamic personality who is known for his skills both nationally and internationally as well. I welcome Dr. Keshav, Senior Cardiologist and HOD Manipal Hospital, Bangalore, and the Chairman KCSI. I also welcome Dr. T. Venkatesh, Cardiologist from Apollo, Bangalore, and the Chairman of Lipid Association of India, Karnataka. I welcome our own organizing team headed by Dr. B. Mahalingappa, Chairman API Karnataka, and his team, Dr. Ravikirti, Vice President-elect National API, Dr. Murthy, National API member, Dr. Suresh Sagrath, past Chairman CSI, API Karnataka, and Faculty Council member of National API. Let us not waste time by reading their CV profile, which runs in pages. Let us hear and learn from them. As I can see, many have joined from all over the country, making a national event, which COVID-19 has taught a new normal life to learn. Idea of combining all associations was to get introduced to the audience and work jointly to control the diseases of atherosclerotic cardiovascular disease in India. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
We are virtually honoring all the faculties as well. We are playing a promotional video of World Heart Day.
This September, don't miss a beat. Join us and people around the world to celebrate 25 years of World Heart Day. Heart disease is the world's #1 killer. It takes the lives of the young and the old and is the cause of 1 in 5 premature deaths. It doesn't have to be this way. Heart disease can often be prevented. With new treatments and healthier lifestyles, many millions of lives can be saved. Not sometime in the future, but right here, right now, today. Don't miss a beat. To beat heart disease, we need you. 1. Sign our petition calling for urgent action on heart disease. Better diagnosis and treatment for high blood pressure alone could save 130 million lives by 2050. Yours could be one of them. 2. Get moving. Join our Keep the Beat challenge. Mark the 25th anniversary of World Heart Day by moving for at least 25 minutes on 25 days in September. Stay active in your own way. 3. Spread the word. Inspire others to take part in our challenge. And if you've been touched by heart disease, share your story. Help others to see the risks before it's too late. Your words can make the difference. There's no time to lose. Act now to save lives. Don't miss a beat.
Now I request Dr. P.S. Shankar sir to address the gathering. Kindly unmute.
Dr. Jyotirmay Pal, Dr. Kamlesh Tiwari, Dr. Malingappa, colleagues and friends. We have assembled today to celebrate the World Heart Day, in which 2 of my distinguished colleagues, Dr. Palajani and Dr. Manoria, and 2 other distinguished students of mine, Dr. Nagaraj Desai and Vivek Javli, are participating. And it has added to my pleasure. Of course, Dr. Sangram and Dr. Venkatesh were also students of mine. They are also actively involved in this. World Heart Day 2025 is observed globally with the theme created by the World Heart Federation, Don't Miss a Beat. This day is a reminder to everyone around the world to take care of their hearts. It is a way to draw attention of the cardiovascular illnesses and their management. According to WHO, 21 million people die every year from the cardiovascular diseases all over the world, making it a worldwide fatality of 33%. Remembering this day is to make people aware about the warning signs of the heart diseases so that people can take steps according to avoid the disease. Since a healthy heart is the gateway to a healthy life, it is the duty of everyone to ensure the health of their heart. And the number of the heart patients has increased worldwide, and it has become a cause of concern in the recent years and has necessitated to create the awareness against the heart diseases and to prevent the heart diseases by adopting healthy lifestyle. And the day was introduced by the World Heart Federation in association with the World Health Organization. The idea was initiated by Antonio Baez de Luna, who was the World Heart Federation president from 1997 to 1999. Heart ailments are among the common around the death worldwide with the stroke and the coronary heart diseases. Cardiac ailments are increasing as more and more persons are taking a sedentary lifestyle, poor diet, smoking, and absence of exercise and obesity. Observation: this World Heart Day has given us an opportunity to spread awareness about the need to undergo the periodic health checkup, they manage the weight, and stay active through different physical activities. Since smoking, high BP, raised level of the blood sugar and high level of cholesterol are the primary risk factors for the heart diseases, attention has to be given to stop smoking, to maintain the blood pressure, maintain the glucose and the cholesterol levels within the normal range. And the day was originally celebrated on September 24th from 2000 until 2011, and it was made marked as the last September, which was later shifted to 29th September each year. There are many risk factors associated with heart diseases and stroke. Some risk factors like family history cannot be modified, while other risk factors like lifestyle changes, the intervention like high blood pressure, they can be modified. And millions of people worldwide struggle to control the risk factors that lead to the cardiovascular diseases, and many others remain unaware that they are at high risk. A healthy heart is a key to happiness in life. Stress and tension are the root cause of all kinds of cardiovascular disease. Hence, one has to stay happy. And the theme serves as a powerful reminder for consistent heart health awareness and the proactive. And this theme emphasizes the need to stay vigilant about the cardiovascular well-being, urging individuals not to overlook warning signs or delay regular checkups, healthy habits, and timely medical intervention. In a world where lifestyle-related heart diseases are on rise, the message encourages everyone to take every heartbeat seriously and prioritizing the physical activity and balanced nutrition, stress management, and routine screenings. Don't skip the beat is not just a slogan, but a call to action to protect the rhythm of life in our hearts. We eagerly waiting to hear the lecture from Dr. Palajani, to be followed by
ज्योतिर्मय
panel
पाल अनम्यूट करें
discussion.
ना.
And I am happy to participate in this particular program. I wish the program all success. Thank you.
Thank you, sir, for sparing your valuable time. Now I request. He has got puja in the house. He wants to leave early. Kolkata. Over to you, Dr. Jyotirmay Paul.
Thank you, respected Dr. P.S. Shankar,
Thank you.
Dr. E.C. Manoria, past President API, Dr. Kamlesh Tewari, Dean, Indian College of Physicians, Dr. Shangram Biradar, Dr. Suresh, Dr. Malingama, Chairman API Karnataka branch, all the respected dignitaries, speakers, chairpersons, and delegate students. I am very happy that in spite of the festive mood across the country, Navaratri and Durga Puja, eastern part of the India, our association does not forget the responsibility to make people aware about heart diseases, because heart diseases now is becoming the major cause of mortality and morbidity in India in this century, which was different, which was 100 years back, it was the communicable disease, which is the major cause of mortality in India. So this is changes because of the changes in the lifestyle, their food habit, sedentary activity, and so on. So our organization, our physicians, definitely we are adapting the management of the heart diseases and the newer techniques. But at the same time, we physicians should spread the awareness of the prevention of the heart disease, because prevention is better than cure. All over India, in different parts, today API has celebrated this day with the walking, then health camp, then spread of the different manuals, leaflet to common people through social media campaigning. And I hope such type of activity will help the people at least to raise some awareness. And this is the festive season, Durga Puja, all will be involved to take more and more fast food. Next Deepavali is coming. So such type of, at the beginning of the festive season, such type of awareness can restrict 10% restriction of taking the high fat fast food. That will be our achievement. Thank you. Thank you. Thank you, everybody.
Yeah, thank you, sir, for sparing your valuable time in spite of your puja and festival season. Now I request Dr. Kamlesh Tiwari, Dean ICP, to address for future.
Thank you, sir. Respected seniors, Dr. P.S. Shankar, President Dr. Jyotirmay Paul, Dr. P.C. Manoria, and other dignitaries sitting here. Today, we are here to observe Heart Day. What is the purpose of this Heart Day? To spread the propaganda and things in the public. Public should know what should be done just to prevent the disease and just to prevent the occurrence. We know that diabetes, blood pressure, hypercholesteremia is the main cause of heart disease, and prevention is the best treatment for the heart disease. So we should take up this preventive aspect first before going to the treatment aspect. And in my opinion, yoga is the best thing in the India because it costs less and effect is much beneficial. In yoga, exercise is already there, diet is already there, meditation is already there. So we can prevent heart disease by means of yoga itself. Cheap and Indian type. Thank you very much.
Thank you, sir. Thank you for sparing your valuable time. Now I request Dr. A.N. Rai, who is the founder president of CCDSI. Dr. A.N. Rai to say a few words.
Thank you, Dr. Sangam Biradar, Dr. P.S. Shankar, other dignitaries. Today is, as we all know, World Heart Day, and the theme is don't miss the beat. The basic principle of this is to make aware every clinician and society how to prevent the occurrence of cardiac disease. And we must be pro-vigilant and watchful. And we should request all those having risk factors or family history that they should come for regular checkup every 6 months or 1 year. So regular checkup, follow-up, vigilance, that is the most important to prevent. And if any person has a risk factor, we should control the risk factor. Otherwise, healthy lifestyle. The most important is healthy lifestyle. If you have a healthy lifestyle, we can prevent the cardiac disease. Thank you very much, Dr. Sangar Biradar. Thank you.
Thank you, sir. Thank you. Now, Dr. Dhiman Kahali has sent a video message. Since he was not able to attend a puja, he will be playing. Dr. Dhiman Kahali is the president-elect of CSI.
I am Dr. Dhiman Kahali, the President-elect and Scientific Chairman of Cardiological Society of India 2025. I first of all congratulate all the office bearers, especially Dr. Sangram Biradar, for this great conference, Update in Cardiology, hosted by CSI, API, and many other organizations in Karnataka. This is my great pleasure to tell that in India, I just point to a, I just point to a single thing that the coronary artery disease is very common in the young individuals, especially between the ages of 30 and 40 or 40 to 45, like that. And more than 50% of the heart attacks and coronary artery disease are in patients below the age of 50 years. So, we investigated why it is occurring in so early age, because it was told that coronary artery disease occurs in early age very much, but what is the cause? And we investigated and we found, like the adult population, all these patients had one or more major risk factors. So if we take care of these risk factors from early childhood, then we can prevent the disease. Like if the patient suffers from heterozygous familial hypercholesterolemia, where the disease manifests at the third or fourth decade, we have to treat the patient from very early age, say 7, 8 years of age, with statins and other hypolipidemic drugs. But I can tell with all the conviction that it's very easy to prevent the disease in these young people if we look at them very early and modify the coronary risk factors. Thank you very much. Jai Hind, Jai CSI, and I congratulate again all of you for the great conference, Sahil. Thank you very, very much.
Yeah, thank you. Now I request Dr. Malingappa, API Chairman, to say a few words. Kindly unmute. Kindly unmute. Yeah.
Good evening, sir. Respected dignitaries. Already it's time late, and all the stalwarts have been talked so much about the World Heart Day, and greetings from API Karnataka. I wish to say only a few words on this World Heart Day. Let's take a pledge to eat healthy, stay active, and care for our hearts, because every heart beat matters. And to have a happy life, you must have a healthy heart. I congratulate Dr. Sangram Biradar to be among inviting me, and also to a co-host of this prestigious webinar. Thank you, one and all.
Thank you, sir. We recognize the presence of Dr. Antani. Dr. Jayant Antani, sir, also has joined. Dr. Antani, sir. Okay, no problem. Now when we move on to the scientific sessions. I request Dr. P.C. Manoria to take over for further proceedings, since all faculty have been introduced. Over to Dr. Manoria, sir. Dr. Palajani, sir, can you share your slide and show?
Dr. Pelajani, he is not seen. Dr. Pelajani?
See me?
Yes.
Yeah.
So Dr. Pelajani will be talking on a very interesting topic, which is of great importance in our day-to-day practice. That is why high incidence of heart disease in the current scenario. Dr. Pelajani, please.
All right, let me take my slides. Good evening, everybody, all my friends from Gulbarga, Dr. Shankar, Dr. Jayant Antani, Dr. Sangram, then of course the chairman, Dr. Manoria, for organizing such a beautiful program. Of course, it is a little late in the day, that also on a working day, but that's how the World Heart Day is sort of observed, because it's always observed on the 29th of September. It doesn't take into cognizance whether it is a holiday or not. As all of you know, this year's theme is Don't Miss Beat. Now, this looks little bit very tall order, because if you look at the number of beats that the heart sort of pumps is 35 to 40 million heartbeats per year.
Sir, you have started sharing your slide?
Yeah.
No, it's not still. Not yet.
Not
Kindly
yet.
share one. Yeah.
Okay, let me see. Go to BXCC and do it? No, I think we'll have to go to. Where is the
Share slide, green.
yeah. It says sign up. So, okay, let me share. Here it is. Here, green button. Is a green button, right?
Yeah, green button, green. Share.
Click on the green. First, open your slide.
Green.
Then click on the green button.
Open the slides, right?
Not on full, just open the first slide.
Okay, open the first slide. I'll have to minimize it. Okay, what the hell is happening?
Open the first one.
Once you click on the share green button, share entire screen.
1 minute, huh? So I go to the green button and then.
Click on the green button.
So first on the Zoom itself, I press on the green button, right?
Now share.
No. Share is here. Okay. This is not the one.
Share button.
Meeting.
Dr. Parajani, first click on the share button, green. Bottom. At the bottom. Hello?
Now, he has to join once again. He has left.
Huh? Or he can send the slide to me, or we can share from here.
Yeah.
Either on mail or WhatsApp, we'll share from here.
आप बात करके बोलते सर.
हेलो.
ने मोबाइल पे बात करिए. एग्जिट हो गया.
ओके.
रीजॉइनिंग. हेलो. Yeah.
Click on the first slides. Sir, click on the first slide. Make it full. Please make it full. Make it full. The full button is on the top, on the brown rim. The full button is on the top, on the brown rim. Number 4.
But we are Zoom, come out of the Zoom, ne?
Sir, the full button for full screen is on the top brown rim. The cup is
Slideshow.
there.
Yeah.
Just click on that.
New slide show.
Slideshow.
There is no slide show.
Or press F5.
F5?
Just press F5, it will come.
You give me F5.
F5 is right, first row. Keyboard
F5.
first row. First row of the keyword.
Yeah, yeah, sure.
1, 2, 3, 4, 5, F1, F2, F3. Just press F5. Or this full screen button is on the brown rim just above, just below my name.
Slideshow.
You just look at the brown rim, there's insert. Just above the insert, that cup is there. Just click on that cup.
1 minute. So what are these things coming up?
Just look at the brown rim. There's a
Brown
cup.
rim, yeah. Brown rim, yeah.
There's a cup.
Slideshow?
Yes,
There's a cup of the slide. Just click on that. It will come.
Okay.
On the cup.
Yeah.
Yeah, this. Yes. Just move it. It is moving or not. Next. Yes.
Yes,
Okay.
yes.
Now you can start. It's perfect.
Okay.
Yeah, camera also you can on. Sir.
You can see me?
Yes.
No, camera is not on.
Audio. Oh, it's on. Video. Audio.
Audio is on. Video is not on.
Video. So you can see my slides?
Yes.
Yeah, slides.
Okay. So never mind. You can't see me. It's okay. The World Heart Day is usually or always celebrated or observed on the 29th of September. And this times the theme is don't miss the beat. Now you can understand how to miss a beat. Is it impossible or possible? Because look at the number of times that the heart beats in a year. It's 35 to 40 million heartbeats per year. And most of them are all asymptomatic. And asymptomatic because majority of the patients who are moving around with a coronary artery disease, they are asymptomatic because they have got a chronic coronary artery syndrome. However, as the time passes by, several of them develop acute coronary syndrome or acute myocardial infarction, and some of the unfortunate ones develop life-threatening arrhythmias, and then they experience a sudden cardiac death. It is estimated that 80% of the sudden cardiac death are due to the coronary heart disease. So it is important that we should realize the significance of the treatment and the prevention of coronary artery disease. Now you look at the world figures. In 1990, the number of deaths due to coronary artery disease all over the world are 42%. Then look at India. In 2020, the number of heart deaths due to the heart diseases has increased to 33%, up from 23%. So this problem is ever increasing. Now, the journey of coronary artery disease has been kind of a challenging from 1958 onwards, and we have come a long way, right from the diagnosis, coronary angiography, coronary artery bypass graft surgery, percutaneous coronary artery disease, and then we started doing PAMI, and then the mechanical cardiac assist devices like IBAP, Impella, ECMO, LVAD are available today to salvage many patients. However, the most important thing, as has been already pointed out and highlighted by the people, that it is the prevention that matters. Now, if you have to look at the prevention, you must know what causes the atherosclerosis. Atherosclerosis basically is because of the thickening of the inner layer of the coronary arteries called as intima. And once this intima starts to become thick, start becoming thickened, and with the lipid deposition and the calcium deposition, the artery tends to get narrower and narrower, reducing the coronary blood flow and producing angina. In some of the unfortunate individuals, or many of them, there's a rupture of this thin intimal layer, and it is because there is a certain pressure on the intimal layer because of hypertension, stress, or some other reasons, and it ruptures and produces a thrombus inside, causing an acute coronary syndrome or acute myocardial infarction. So therefore, if you look at the acute coronary syndrome, this is the terminology which is now very loosely and very commonly deployed and shown in the several of the articles. The acute coronary syndrome basically consists of three subdivisions. Number one is the STEMI, which is ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina. Unstable angina is just one step before the formation of the clot. It is a roughening of the intimal layer with some platelet aggregation, which causes the unstable angina. However, some clot occurs which is non-occlusive, not totally occlusive, produces non-ST elevation myocardial infarction. Once the thrombus becomes totally occlusive, it produces an acute myocardial infarction. We do see nowadays, and it has been well investigated, that there are several patients in whom you might have done the CT coronary angiography. You might have seen that and then went for coronary angiography for a certain reason. Sometimes in the near future, they develop an acute myocardial infarction. And we have started recognizing a condition called as thin cap fibroatheroma. In that, the cap over the atheroma is very thin, and it sort of is very thin layer. There's a lot of fat deposition underneath this, and any stress like hypertension, stress can cause a rupture of the plaque like this and produce an acute myocardial infarction. For example, here's a patient who had a very minor lesion in the coronary arteries, and he developed an antival infarction. We did an IVUS on him and found that the inside layer is very thin. Maybe there's some deposition of the fat here, but there's a rupture of the intimal layer which produce a myocardial infarction. So therefore, in other words, we know that there is an entity which is called a thin layer fibroatheroma, which despite the fact that the coronary arteries may be normal, that patient can develop myocardial infarction. These patients can be picked up only by IVUS, or sometimes even on the CT coronary angio, if we see sort of the soft plaques as they are called. Now we also nowadays divide or categorize myocardial infarction into type 1. Type 1 is basically due to the thrombus production, which causes a complete cessation of the blood flow, producing an ST elevation myocardial infarction. Or we can get a type 2 myocardial infarction, in which there may be not thrombus, but it's just a little narrowing, or sometime due to the reduced oxygen supply in the face of increase of oxygen, myocardial oxygen demand, patient can develop a myocardial infarction. Unfortunately, what we see nowadays that it is the women and the young people who are developing a coronary artery disease. Now, coronary artery disease in women is increasing as much as in men. There is no gender advantage beyond menopause. Then the risk factors in women are more or less same as in men. In fact, the prevalence of many risk factors, obesity, is higher in women. So this is how a woman would present with a sweating, feeling unusually tired. Why I'm saying this? Because the symptoms of coronary artery disease in women are slightly different than the men. It is usually they feel a little tired, fatigue, and therefore most of the symptoms are neglected. The stress test is more likely to be inaccurate because they cannot perform the stress test to the fullest, and the disease is more extensive and severe as compared to the men, and medical or surgical treatment associated with greater risk of complications. Hence, the prevention is all the more important. Now, once the infarction occurs, you see the patient develops an ST elevation myocardial infarction. Here's a patient who came with chest pain of 2 hours duration, and you see marked ST elevation in V1, V2, V3, V4, indicating an anti-wall infarction. Now, what does one do in such a patient? The most important is the patient himself. There has to be a patient compliance. Patient should always be vigilant and should be trained to recognize the symptoms of acute myocardial infarction so that he can seek the medical treatment attention immediately. An ambulance can come and ship the patient to the emergency medical services, make a diagnosis and a prompt treatment, and treatment within the window period can be given. So actually the first actor in the diagnosis and treatment of acute myocardial infarction is the patient himself. He should be trained. Actually, it should be a widespread campaign to train the people that how chest pain patient with acute myocardial infarction is presented with a chest pain. And in every community, anyone with a worthwhile medical facilities should have an ambulance on the call, and therefore within first 12 hours of symptoms, the patient should be transferred to the PCI capable center for undergoing an angioplasty to sort of restore the blood flow. Because it's very important to do the procedure within a short period because it is time bound. If you delay, the loss of myocardium is much more. Earlier you do more salvage the myocardium will be. So therefore it is all time bound. So if you did an angioplasty within 60 minutes, you save more muscle than if you did the angioplasty at 360 minutes. So for every 1 hour loss, patient loses about 6% of the heart muscle. For example, here's a patient who had an ST elevation myocardial infarction, a similar same one which I showed you, 2 hours chest pain, and you can see here the patient underwent an angioplasty, a tight LAD lesion, diffusely diseased here, and after the angioplasty, the blood flow is completely restored into the LAD. However, you would say that it's not feasible. Certainly, it is not feasible in every city, in every town, because particularly in a city like Bombay, Delhi, there are traffic jams. So therefore, how does even an ambulance come through this? So how does one treat such patients? There is another method of treating these patients. If you feel that the patient is going to be delayed, transfer is going to be delayed for more than 3 hours, what you can do is to give a thrombolytic agent or fibrinolytic agent to the patient intravenously. If you are giving tenecteplase, you can give 30 milligrams intravenously stat. Then make an arrangement to transfer the patient in the PCI capable facility. And if the patient reaches there within 12 to 24 hours, a delayed angioplasty can be performed, and more or less these pharmacoinvasive results are more or less comparable to the primary PCI. However, if you delay, what can happen? Here's a patient who came after about 14 hours after anti-wall infarction. We took him because he was getting some pain, breathlessness, did an angiogram, and you can see the LAD is opened up to here. But there was a completely on and on a thrombus moving or migrating into the LAD and would not reach here because there was a fragmentation of the thrombus which kept on blocking the distal vessels. So therefore, the time is of great essence. You got to try to shift the patient to the PCI capable center within 6 to 8 hours time. If you can't, give a thrombolytic agent, ask the center to do a pharmacoinvasive treatment, and angioplasty should be performed within 24 hours. Unfortunately, now the attention is being given to the young adult coronary artery disease. The definition of young adult changes or is varied. Some consider 40, some consider 45, some consider as 50. Now, most of these patients, young patients, present to you with acute coronary syndrome or myocardial infarction. They do not present as the chronic coronary syndrome. They usually do not present as a stable angina. Their symptoms are most of the time, many times, are atypical: nausea, vomiting, weakness, sometimes fainting attacks. And most of them, if you did the angiography, you will find that the commonest number of vessels are single vessel disease. However, there are no collaterals. Because there are no collaterals, the patient develop an acute myocardial infarction, and it is most of the time due to the ruptured plaque. Now, what are the risk factors for this? Why younger patients are developing the acute infarction at such a young age? There are many factors which have been looked at. Most important are body mass index, more than 30, hypertension, uncontrolled diabetes, smoking, dyslipidemia, family history, abuse drugs, depression, creatinine, and low HDL. These are some of the risk factors which have been found out in these patients, which can cause the acute infarction. Now, there's been a very nice study from Jaipur, and my friend Dr. Rajiv Gupta had done this extensive study, went into the villages around in smaller towns in Rajasthan, and he found several things. That the occurrence of coronary artery disease prevalence and the obesity and the hypertension and the diabetes was proportionate to the budget and the prosperity. So it is kind of India becoming more prosperous, the budget's increasing, the patients develop these things. So how do I actually investigate these patients before they go for an acute or develop an acute myocardial infarction? You have several methods to do it. ECG is only 30% accurate. Stress test is only 50% accurate. The accuracy of thallium is 85%, 80 to 85%. Dobutamine stress echo is 80 to 85%. Now I put more stress wherever I find that there is a likelihood of a coronary artery disease. I depend more on the CT coronary angiogram. A test can be done within 5 minutes, and you get a good delineation of the coronary arteries, LAD, circumflex, right coronary artery. You can even find out whether the patients have got a sharp plaque like this, which is likely to rupture. Or if the plaque is there, many times people do calcium scoring. But the calcium scoring gives you only total amount of calcium. It doesn't tell you whether the calcium is in the lumen, in the intima, or is it in the adventitia. So it falsely gives you an impression as if this patient has got a coronary artery disease. This patient can be easily left alone because there's no soft plaque. Whereas here's a patient who has got a soft plaque, calcium. So this patient needs further investigation. I personally lay more stress on doing a CT coronary angiogram. So residual risk occurs after myocardial infarction. And for that, one has to do lifestyle management, statins, ezetimibe, bempedoic acid, PCSK inhibitors, and inclisiran. So what does one do? Before knowing that, what we should do, we should also realize that if a patient had a prior ischemic event, be it acute infarction, be it unstable angina, be it non-ST elevation myocardial infarction, or even chronic stable angina, if a patient had a prior ischemic heart disease symptoms, the event rate because of the residual coronary risk are much higher in the patients who did not have any prior ischemic event. And in them, currently, there's an excellent drug called as inclisiran, which actually enhances the production of LDL receptors, which sort of pick up the cholesterol from the body and reduce the calcium. Now, there has been trials between statins, ezetimibe, and inclisiran and PCSK9 inhibitors. Apparently, the first line of treatment has to be statin and ezetimibe because that is easily available, is inexpensive. Patients, if they can tolerate, nothing like it. But if there are several patients who cannot tolerate, they get myalgia, myopathy, myositis. For them, the drugs like inclisiran or Repatha are really boon. Inclisiran is given in the doses of 1 injection at the index time, another injection after 2 months, and then every 6 monthly, 1 injection of 250 milligrams is given subcutaneously. And there is a 57% reduction in the LDL cholesterol levels. And one can sort of bring it down to 2 doses a year also. And this regimen not only I've seen reduces the LDL cholesterol, but increases the HDL cholesterol level also. Alternatively, one can go on the evolocumab, that is Repatha, which also has been found to be very effective in these patients to take care of their residual risk. So in conclusion, sir, ladies and gentlemen, coronary artery disease is the major cause of death and morbidity and mortality. More common in Asians because I think we carry more risk factors like diabetes. India is becoming the world capital of diabetes. We have tremendous stress because we want to now come up to the level of the Western world. They already got enough money, so they don't sort of put so much of effort that a growing or an ambitious Indian puts in. Then we have uncontrolled hypertension. We are not aware of the risk factors. And therefore, what's happening? The incidence is increasing in the young adults and women. For them, the lifestyle modification, as has been stressed by the earlier speakers, is the most important factor. All the factors to be taken care of: obesity, truncal obesity particularly, modifying the lifestyle, smoking cessation, drug abuse cessation, hypertension control, and of course genetic factors you can't change, that you inherited. A stress, cutting down the stress by yoga, meditation, and doing regular exercises. And of course, if the patient still develops an infarction or acute coronary syndrome, timely treatment of myocardial infarction should be undertaken. Well, thank you very much, ladies and gentlemen. I do hope, sorry for the initial mix-up, but I'm sure I might have made some initial bungling, but I think everything must have gone all right. Thank you very much.
Thank you, Dr. Palajani, for a very informative and an excellent talk. I think coronary artery disease is reaching alarming and epidemic proportions in our country. And unless we address the masses also, besides the medical fraternity, the incidence and prevalence of coronary artery disease cannot be decreased. So one of the simplest way to address masses in the context of coronary artery disease is the major culprit of coronary arteries S. S means saturated fats, sugar, salt, smoking, stress, sleeplessness, and sedentary life. So if you remain away from these 7S, coronary artery disease will be minimized to a great extent. So my dear Nagraj is there. So Dr. Nagraj, one of the questions which is often posed is fast food kills faster. Is it a myth or reality? Is it a myth or a reality? And what is the definition of fast food? Dr. Nagraj, please.
Dr. Palajani, can you stop sharing, sir?
I did, Dr. Manoria,
Yeah.
I didn't hear the question clearly. Can you
Yes.
repeat it, please?
Yes. Fast food kills faster. Is it a myth or a reality? Your comments, please. And what does fast food means?
See, whatever scientific evidence that is available today, fast food, because of its richness in the fat and unhealthy fats, and also finer carbohydrates and a sugar content and salt content, on all counts, it is a kind of, it militates against the good, healthy habits. Such being the case, it is reasonable for us to say that fast foods really are not good for health. And it is up to you to decide whether it is going to kill you faster or not. But in my opinion, it is an unhealthy option that one should go for whenever you go to a restaurant or whenever you order Swiggy or anything like that. So I hope I have made myself clear
Yes.
that fast food is not healthy at all. Thank you.
Dr. Keshav, how does a diabetic infarct differ from a non-diabetic infarct? We have 101 million diabetics, 136 million pre-diabetics. So how does a diabetic infarct differ from a non-diabetic infarct? Dr. Sanam, Dr. Jolly is there?
He'll be joining, he told, because he's in theater operating.
Okay.
I will let you know. Dr. Keshav, kindly unmute.
Diabetic heart disease. Before that, I would like to thank Dr. Sangram Biradar and Professor Dev Palajani. He was my teacher. I held him in high regard, and so is Dr. Manoria. I think you may not remember. We used to attend his talks for JPI and all. Diabetic heart diseases, more silent, more severe, more extensive, diffuse. By the time it's diagnosed, it's already multivessel, triple vessel disease. And patient will, most of the time, you are forced to consider surgical revascularization as the first option. That was the initial learning thought. But nowadays, with the intervention of PCI, you can do it even with multivessel. For diabetic coronary artery disease, more severe, more triple vessel disease, and more silent heart attacks, and more also this distal diffuse disease, microvascular disease is also more common in diabetics. All of this predispose to bad prognosis and bad long-term outcomes.
Dr. Pelajani, we like to have your expert comments on the lipid targets and some comments on the Lipid Association guidelines.
See, I'll tell you what. I believe in the very low levels of LDL cholesterol. I mean, though the lipid associations they said 75 milligrams or 70 milligrams as the target, but as far as I'm concerned, I will consider 50. And when patient has had an acute coronary event, I will keep it even at 30, 35. My principle is lower the better. Lower the better. As you know, some of the animals who have got as low cholesterol as 15 milligrams, 10 milligrams, they don't develop coronary artery disease, you see. And so therefore, I think it's the LDL, which is a culprit. So my target, if I get to 20, 30, I'm happy. I'm not bothered about going down to low, very low to the LDL cholesterol. As a matter of fact, some patients have been on Repatha. And with the Repatha, I've seen that LDL cholesterol going down to as low as 5 to 10 milligrams. So, and they do well. They have no symptoms. They're very good. On the contrary, they get more symptoms with the statins. So I think though they considered the target is 70 to 75 milligrams, but for me it is less than 50 milligrams.
I think all of us know that atherosclerosis progression stops at 70. So at least for primary prevention, even in low risk, we should try to keep it 70. Regression starts when LDL is less than 50. But the dicta as told by Dr. Palani, lower is better and lowest is best for the very high risk patient. So if you have very high risk patient, maybe 20, 30 as also endorsed by the Lipid Association guidelines. Dr. Nagaraj, one of the thing is that is a combo of mild elevation of multiple risk factors more dangerous than severe elevation of single risk factors? Often the patient tends to believe that it's mild diabetes, mild hypertension, mild dyslipidemia. Is it the common combo which produces myocardial infarction or a serious elevation of a single risk factor? Your viewpoint. Dr. Nagaraj, please. Dr. Nagaraj? Dr. Nagaraj?
I think Dr. Keshav is there, sir.
Dr. Keshav, your comments.
I think multiple risk factors, even if it's low, it multiplies. Single factor, so if you say diabetes plus smoking, actually it becomes 4 times instead of 2 risk factors. So multiple risk factor, the overall risk multiplies rather than addition. So I think we should always treat aggressively the risk factor, even if it's mild. Otherwise, the patient will end up in a complication.
So the patient should be clearly told if you have mild elevation of multiple risk factors, that is more dangerous than a serious elevation of a single risk factors. Dr. Nagaraj, you are there? He is left.
No, he is there.
No?
I will call him. He is there, so he is there. Dr. Palajani
Dr.
can take.
Nagaraj? Some problem with the internet. Dr. Nagaraj?
Yeah. Dr. Palajani sir is there. He can take.
Okay. So, Dr. Palajani, besides the risk factors told by you, air pollution is also now recognized as an important risk factor for cardiovascular disease, including coronary artery disease. It has been shown to produce hypertension, myocardial infarction, heart failure, arrhythmias, even stroke. Particularly the PM2.5 particles are very important in this context. So what are your comments on air pollution and the link between air pollution and cardiovascular disease? And what could be the preventive measures we should suggest to the government? The government, of course, is not very active in this direction.
I think carbon monoxide and other sort of a pollutants. It is just not the carbon monoxide. If you see if you look at the air purifier, and that the material which is collected in the air purifiers, it is not only carbon monoxide. There are many other pollutants. I think all those pollutants combined do affect our the oxygen saturations. They sort of increase the platelet adhesiveness, and the lung capacity reduces. The microvascular damage is there. So I think this is being considered as one of the important risk factor for the coronary artery disease, though it is not highlighted quite well into the literature. But my feeling is that it certainly increases the incidence. But how many times, how much percentage, I think still it has to be sort of a certain. But certainly, I think probably it must be causing so many other things like diminished oxygen saturation, diminished capacity of the lungs, lung diseases, and reduced oxygen saturation in the blood. I think it is definitely can be risk factor.
The World Heart Federation has brought out a very interesting monogram last year. Dr. Keshav, obesity is reaching alarming and epidemic proportions, and we send lifestyle modification in central to the treatment of obesity. But now we have two molecules, semaglutide injectable and tirzepatide. So your viewpoint on both these molecules, and how do you select between those? Suppose an obese patient comes to you with coronary artery disease.
Just recollecting what Dr. Palajani said, there are a lot of articles which has shown clearly pin patient stay and the coronary artery disease. This is all Western literature. The patient stays in a polluted area. This pin code higher pollutant, what you told 2.5 ppm, they have a higher disease. So pin code also says, suppose you're saying close to a signal, your pollutants are high, your chance of disease is high. So it's very well proven beyond doubt that in West, some pin codes have a higher CAD, some pin codes have a lower CAD. And it was said that if you give an air purifier in people in areas where this pin code showed higher pollutants, the incidence of CAD has come down. That's one nice evidence I had encountered recently. Regarding the obesity, there is no doubt apart from SGLT2, GLP-1 analogs are come in a big way. Semaglutide or tirzepatide, both are very excellent in patients with CAD. Both are extremely good. Tirzepatide to 20 to 25% weight loss, and semaglutide up to 15 to 20% weight loss have been demonstrated. Over and above the weight loss, the coronary artery disease, mortality, and endpoints in the studies, SOUL study and SUSTAIN study has shown that the excellent result. I think it is going to come in a big way. As of now, the cost in the major inhibition almost comes to around 18,000, 15 to 20,000 rupees per month. But cost aside, it's a very excellent drug. Mortality comes down, and so it's got a good future in the thing. As of now, both are equal. Maybe tirzepatide has got more weight reduction compared to semaglutide. But overall, it looks like both are equally efficient. But Mounjaro tirzepatide has a different action compared to semaglutide. So I think a lot of molecules are coming. Some are expecting almost 30% weight loss in the future. So it's a good, interesting set of molecules we should watch for. I think we are using in patients where obese, diabetic, and cost is not an issue. I think it should be the first choice.
Dr. Palajani, time and again we hear young celebrities dying in gym. If he's not a celebrity, it may pass unnoticed. So your brief comments on these deaths in gym. Dr. Palajani, please.
Am I mute or unmute? I am unmute, right? You can hear me?
Yes.
This is a phenomenon we have been hearing. We have been hearing people dying in the gym. We have seen people, I heard about people dying while giving a show on the stage with the strenuous dancing. And I think it's probably what I was talking about. These people these are young coronaries. Now, most of them are young. They are high stress guys. Most of them are executives because that's how they they can afford to go to a gym. Many of them are stage performers, and so they earn a lot of prosperity. Now, whether they had a pre-existing coronary artery disease or not, but some of them swear that they did not have, and they develop chest pain while going on a treadmill or bicycle. And I think it is some of them may be having what I talked about, thin cap fibroathyroma. And maybe while doing a stress test, while doing on a gym, the thin cap ruptures and produce a thrombus and produce acute myocardial infarction. So some of them are of that type because they did not have any symptoms. As I said, some of the young people do not, actually young adult coronary artery disease does not get chronic coronary artery disease symptoms. they usually present an acute myocardial infarction. Some of them just die on the treadmill. So, I mean, this is a different subset of patients we are seeing. So that's why I strongly suggest to many of these people to undergo a CT coronary angiogram. And if there's a soft plaque, invariably, you will be able to pick up. And if you see a soft plaque, then there's an aggressive lipid lowering therapy, which can take care of them along with a small dose of aspirin.
I think what is also important to realize that if you go to a gym, your physical fitness may be very good, but your cardiometabolic fitness may not be optimum. You may have high blood sugar, you may have high cholesterol. So going to gym does not make an individual immune from coronary artery disease or cardiovascular disease. The misconception often prevails. Lastly, Dr. Pelajani, some comments on the role of polygenic risk factors. Are they going to be useful in prevention of coronary artery disease in times to come?
What is it?
Polygenic risk score, monogenic and polygenic risk score, to predict coronary artery disease in an individual. And are they going to be useful in times to come?
Yeah, I think these risk score, to start with, there was a Framingham risk score. Then there are so many other risk scores like atherosclerotic sclerosis determination or predicting the coronary artery disease events in the next 5 or 10 years' time. I think it is good to at least sit down and any patient coming to you, look at his diabetes, hypertension, cholesterol, weight, and genetic history to predict what is his score, that whether one can predict a coronary artery disease in that individual or not, so that one can sort of start the preventive measures in such a patient.
Dr. Sangram, we can now open the session for question and comments. You can open it.
Yeah, there are no much questions on the chat box, sir. Yeah, everybody is concerned about the young, heart disease in young. That was the main motto for conducting this thing. So if you can pass on some key takeaways for causes for heart disease in young, precautions and things to be taken.
Heart disease in the young, as I had shown, most of these risk factors which exist in the adult one or the grown-up one are also exist here also. Most important is truncal obesity, the high creatinine, blood sugar, hypertension, smoking, stressful lifestyle, then substance use. I think one should not forget substance use and lack of exercise. I think people forget about the performing exercise every day. As a simple method can be, one should do at least nothing else. One should do at least 10,000 steps every day. Nothing else, at least 10,000 steps every day. That will keep your muscles going, your blood circulation going. Of course, going to the gym, taking your heart rate to 70% of your target heart rate will keep your heart fit. Then, of course, yoga, meditation, all these things work well to prevent coronary artery disease. There has been also, just for our listeners and viewers, there has been a lot of work, discussion, that if a patient who has got a strong genetic history of developing a coronary artery disease, now can you modify that? Because it's non-modifiable. But now there's a lot of work going on what is called as an epigenome, genome and epigenome. And in that, working hard on the factors like exercise, stop smoking, then substance use, avoiding lipid lowering drugs, reducing obesity. They say that these genes, which were otherwise to produce atherosclerosis, they can be modified by a process called methylation. And they can get blunted. And therefore, the genetic mode of the causation of the coronary artery disease can be blunted. So just don't think that just because you got a genetic history that you can't do anything. Do all these measures and blunt those your genes by the system, what is being known more and more recognized as the epigenome theory.
Does artificial intelligence will help to some extent in future, sir, for predicting predictors for genetic markers?
I think so, because as such now there are a lot of labs here, and I think all over the country who are doing the genetic markers. They do genetic markers for cardiomyopathies, for the channelopathies, for the coronary artery disease, and then hypertrophic cardiomyopathies. So there are genetic markers being looked at, but I think at the moment the whole field is in a very nascent stage. So I don't think many people understand also what one should do, what one should not do. But it is like this. I mean, crudely also you can say that if there's a family history at a young age in the family, daddy, mother, and uncle, grandfather at a younger age. Younger age means less than 65 years of age. Then you should consider it as the good marker for the genetic marker of coronary artery disease.
There's a question in the chat box. Those who are sensitive to contrast, what is the protocol for coronary angio? They can get a stress thallium done if you are sensitive to.
Yeah, vitamin stress echo.
Stress echo, stress thallium.
Yeah.
So
Yeah, vitamin stress echo.
okay.
Achha, now I think let me answer that question. That knowing that the patient is allergic to the contrast must have come by somebody might have gone for the intravenous pyelography or might have gone for CT coronary angio, and through the intravenous route he developed the reaction. But let me tell you that the body arterial system handles the dye a little differently from the venous system. When you inject the dye into the venous system, then the chances of reaction, allergic reaction, are much higher because the dye goes through the lungs where the basophilic structure is much more, which produces an allergic reaction like wheezing, the hives, and whatever symptoms of an allergic reaction can come. Whereas when you give intra-arterially for doing a coronary angio, it goes through the arterial system, doesn't go to the lungs. So these people tolerate dye or the contrast much better than they will tolerate the intravenous dye, number one. Now, suppose we have found that the patient is allergic, he needs a coronary angio, he needs a coronary angioplasty. Then what we do, this is a protocol. We give them the F-Corlin or the F-Corlin, some 200 milligrams before, give them H2 antagonist some 2-3 hours before intravenously, and then take them, give them a test shot by 1 cc into the aorta and see if we cannot. Actually, my experience has been wherever these people have come with the intravenous route contrast allergy, I have not found intra-arterial allergy. I think somehow that the contrast allergy occurs, but I think it's not as much as it has been hyped.
Yeah, Dr. Venkatesh, any comments from you? Dr. Venkatesh? Okay. So if there are no other further questions, before Dr. Suresh gives the concluding remarks, let us have a take-home message from each. So what is your take-home message for the audience, Dr. Palajan?
Take-home message for the audience. Hello.
From you, take-home message from you.
Message from me. First of all, as I have said, that now you recognize the young coronaries, the coronary artery disease in the women who present to you with women will present to you with very atypical symptoms. Don't neglect them. Investigate them thoroughly. Look at their risk factors. Look at the obesity, diabetes, high cholesterol, and then investigate them like any other man who comes to you with acute symptoms. Women come with very atypical symptoms, number one. Number two, and remember, the
estrogens now have failed to give them protection because of the many other risk factors like cholesterol, obesity, diabetes. They are causing an additive factor causing coronary artery disease. Whereas in the young people, please educate all your young patients, young friends, and tell them that these are the risk factors which you should take care. And I already enumerated those risk factors and ensured that they go for regular exercise, go to the gym, avoid smoking, avoid the drug abuse, then get their clinical checkup done periodically once if they are above the age of 40, because now we are seeing a lot of patients coming above the age of 40 and 40, 45, 50. So they come for a regular checkup above the age of 40. If you have any doubt, single doubt, that the patient may be having the chest pains which are not classical, of course you will investigate. But if they are borderline, feel free to get your CT coronary angio done. I don't sort of lay much stress upon the stress test, the thallium, or on the vitamins. I do it if the patient can't sort of doesn't want to go for the CT coronary angio because of many other. Do you look at the thallium scan cost? Thallium scan cost itself is 15 to 20,000 rupees. The cost of the CT coronary angiography is also 17,000 rupees. So you're getting a better clarity on the coronary artery anatomy. Thallium scan or the SPECT thallium I'll do for any viability study. That's a different issue altogether, but not for the diagnosis of coronary artery disease.
Yeah, thank you, sir. Dr. Keshav, your take-home message for the audience.
I think awareness has to go up. Once awareness is there, I think more and more public awareness about the risk factors. Smoking is still going up. Diabetes, blood pressure control has not been emphasized. Cholesterol control has to be overemphasized again. Lifestyle modification like exercise, obesity, physical activity. Sitting is the new smoking has to be emphasized for all the software crowd. And genetic family history, frequent checkups, all the things have been already enumerated. But I think we have to keep on hyping these risk factors to the public so that they are aware, so that they can change and change their lifestyle and take care of their life.
Thank you. Dr. Manohar sir, your take.
Eat less, eat right, eat in time, walk more, sleep well, and smile.
Thank you, sir. So now I request Dr. Suresh Sagrath for your closing remarks before we conclude.
Thank you, Dr. Sangram sir, for this wonderful World Heart Day CME and webinar. So initially, this seminar has been organized in collaboration with our API, ICP Wing, CCDSI, CSI. So many organizations have involved to create awareness about the coronary artery disease, which is highly prevalent in our Asian subcontinent. And I thank Dr. P.S. Shankar for opening remarks, along with inauguration by our National API President, Dr. Paul, and also Dr. Roy, who also gave his very interesting message. And of course, the speaker, Dr. Palajani, has highlighted a lot of issues about coronary artery disease, ACS, and its management protocols, and how to intervene at what levels regarding primary, secondary, and tertiary preventive aspects. Of course, we had a very good discussion about the various issues surrounding coronary artery disease, along with Dr. Nagaraj sir, Dr. Keshava sir, and very well moderated by Dr.
Dr. Manohar sir.
Yeah, Manohar sir. So all in all, it's a wonderful evening to spare time on coronary artery disease on a very important day, which touches the lives of millions of people across the world. And I sincerely thank Dr. Sangram Biradar for organizing again and again very good webinars on Zoom platform along with ACP Karnataka as well as national. And Dr. Tiwari has also gave us a message. He was a ICP dean. Thank you, one and all, for participating actively in this webinar. Thank you very much, sir.
Yeah. Thanks for all the delegates also who have joined. Thank you, one and all. So we sign away first. Thank you, sir. Thank you.
Thank you, sir. Thank you. Good night.
Thank you.
Thank you.